This episode of the Curbsiders is sponsored by Pediatrics On Call, the new podcast from the American Academy of Pediatrics. Each week, hear the latest news on children's health with advice and tips for doctors and parents alike. Subscribe to Pediatrics On Call and visit aap.org/on-call. The Curbsiders have partnered with VCU Health Continuing Education to offer free continuing education credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org to create your free account and to start claiming CE credit.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Paul, we're back. This is another Hotcakes. It's been a little while, and we actually kept on track tonight. With us is the great Dr. Rahul Ganatra and our fearless producer, Sarah Phoebe Roberts. Before we get to them and our picks of the week, Paul, can you tell people, what do we do on this show?
Such a great question. Typically, who we are is we are the internal medicine podcast. And what we do is we interview experts to bring you clinical pearls and practice-changing knowledge. But this time, the experts are us, ? I mean, I feel like Rahul has some expertise, and then we sort of muddle through some cases, and he tries to make us sound not dumb, and does so heroically most of the time. So this is our much-beloved Peabody Award-winning Hotcakes series, complete with a new scoring system that you'll hear all about later on.
And I would like to apologize to all our older listeners for a later comment that I make, which was a bad joke that they won't let me edit out, so I apologize. Paul, why don't you give us a pick of the week?
Why don't I do that, Matt? I will, because you asked.
Don't sass me, Paul.
So I'm going to recommend a podcast. As I've revealed in prior episodes, life has been somewhat or comparatively joyless for me, and so anything that sort of brings me a small modicum of happiness, I have to talk up. So I'm going to recommend a podcast that most people will hate called "You Talkin' Heads to My Talkin' Head," which is a spinoff of. So I don't know if you remember the
Are
the
You
Adam
Talking
Scott,
You Two to Me?
Yeah. So they did "Are You Talking REM Me," and then they came out with an "Are You Talking RHCP Me." So they were going to do a Chili Peppers podcast, which I would have listened to and would have hated because they are not a good band. But then the second episode, they just decided that they were not having a good time and immediately switched to the Talking Heads and have been sort of going through the Talking Heads albums. And if you've ever listened to any iteration of the podcast, they spend about 5 minutes talking about the music and about, I don't know, an hour and 25 minutes just kind of screwing around. So it's
talking
it's
about
hilarious.
how they have the same name.
Yep. And then you're right. And then doing sort of sister shows that are then nested within other sister shows. And the whole thing is just kind of this chaotic mess, which I love very much. So if you need to sort of put your brain on hold for a little bit and actually just enjoy something and laugh at two very funny people who talk about music occasionally, I would recommend You Talkin' Heads to My Talkin' Head, which is on the Earwolf Podcast Network.
The name is
rolls right off the
fantastic.
tongue. It's spectacular. It's reason enough to listen, I think.
Sarah, were you going to give a pick of the week?
Well, I was going to give my pick of the week as the beautiful new recalibrated Hotcake scale that Rahul came up with.
Oh, so that's a good tease for that. I think we should say that a little bit later.
Oh, okay. All right. I will mute myself and exile myself. Goodbye.
Rahul, what's your pick of the week?
Well, I also have a musical pick of the week. People are familiar with the electro-funk duo Chromeo, right?
No, but please tell us about them.
So
I am, because I'm cool.
Thank you, Sarah.
I know you're
somebody.
Just unmuted herself specifically to make that point, by the way.
Okay, so Chromeo, they are these two DJs from Montreal, and like much of the world, they have been holed up during quarantine, during the pandemic, but they have been very productive, and they have actually produced an album called Quarantine Casanova that's really just delightful. If you like funk, dancey, fun, lighthearted music, it's really great. It's all pandemic-themed stuff. It features such tracks as Clorox Wipe, and 6 Feet Away, and Roni Got Me Stressed Out. I could go on, but you get the idea.
That sounds just wonderful. All right, so I'm going to give a pandemic themed pick as well. I'm changing it up last minute, Paul. I am rewatching 30 Rock, and I was texting Paul this just fantastic line. Jack Donaghy is Alec Baldwin's character, and he has at least one just amazing line on every episode. The one that I think I sent to Paul was they were talking about the page Kenneth, and Jack goes, "In 5 years, either we'll all be working for him or dead by his hand," which I just thought was a fantastic turn that I did not see coming. And I'm just waiting for the right situation to use that quote in real life.
It's about, God, at least once a week, probably a couple times a week. I think of his line when Liz Lemon walks into his office and says, "Why are you wearing a tuxedo?" And he says, "It's after 5 o'clock. What am I, a farmer?" I just think about that often. I will never have an excuse to say it, but I enjoy it very much.
And that's in like one of the first 6 episodes. They just came right out the gate with like these amazing quotes. So if you haven't watched it, or if you haven't watched it in a while, it's fantastic. So with that, maybe we should talk about our new Hotcakes rating scale. And Sarah, what do you think about this? Is this something that are we going with this?
I mean, I think if we want to be taken seriously, we have to have a more rigorous, research-based, evidence-based scale. And that's what Rahul has delivered to us.
Paul, I believe about 5-10 minutes ago, we actually heard Sarah say this is definitely the most evidence-based Hotcakes rating scale that I've ever seen, or pancake-based rating scale.
It's definitely the most pancake-related, most rigorous pancake-related scale I've seen thus far.
Well, now I'm feeling self-conscious. I can't tell if you're making fun of me or not.
I would never do that.
Maybe since Rahul came up with this, it's a 0 to 5 scale, right? So I guess 5 would be the equivalent of a full stack at this point. And Rahul, you want to tell us what's a 0 and what's a 5?
Sure. Well, a 0 hotcake study is one that I would say is really quite severely limited by bias or chance, and the results of the paper probably are very different from the truth. I would consider this very low quality evidence. And a 5, or a full stack, this at the other end of the spectrum is a study that is creative, memorable, innovative, highly practice-changing, high-quality evidence, and delicious.
All right.
Less vulnerable to bias and chance.
So maybe as we're going through these articles, we can refer back to this scale, and it'll probably take us a little while to learn it, but I get the idea. I like it. Paul, will you allow it?
I hate it so much. I love you, Rahul. There is no chance of lending any kind of legitimacy to this. The fact that we're trying makes me hate hotcakes even more, but God bless you for trying.
I knew it.
I said with love towards you and hatred towards the hotcake scale, which I've hated from minute one and have not been able to get off of the show. So, and now I think you've probably firmly ingrained it as part of our methodology. So thank you for that.
And I thank you for the scale and for the fact that Paul hates it, which gives me great joy, even though he is one of my best friends, still. Rahul.
Well, I think, Paul, then you would love my new podcast, Hotcakes Talking Hotcakes with the Hotcakes into Hotcakes. Have you listened to it?
I mean,
it's really good.
It seems mostly at my alley.
A little esoteric.
Yeah.
Rahul, can you tell us about this first article?
Sure. So the first article...
Just a seamless transition, by the way.
I'm muting myself again. Goodbye.
I'm pulling us out of a nosedive, Paul.
The Curbsiders are sponsored by Pediatrics On Call, the new podcast from the American Academy of Pediatrics. This is a weekly podcast for those of you who have made the heroic and dubious question to provide medical care to children. If you do that, this podcast will hopefully help you do it better. Each episode will discuss issues like obesity, mental health, keeping children safe at home, which of course is especially germane during this time of coronavirus. If you're interested in this type of thing, and I don't know why you wouldn't be, please visit aap.org/on-call for the latest episodes.
Okay. So the first paper that we're going to be talking about tonight has made a lot of waves in both the lay press and the medical media, and rightly so. This is really important practice-changing stuff that we're covering here. So this is the recovery trial, which was published recently in the New England Journal of Medicine. And this is the preliminary report of a large, ongoing, multi-center, multi-arm trial in the United Kingdom. And this is just the report of the arm involving steroids, because this is kind of an important thing to, have everyone have access to this information at this stage in the pandemic. So the question that the authors were asking was, does treatment with glucocorticoids, and specifically in this study dexamethasone, reduce the 28-day all-cause mortality among patients who are hospitalized with confirmed or suspected COVID-19? Okay, so this was a really large study that was done at like over 170 NHS hospitals in the United Kingdom. And something like 15% of all patients hospitalized in the UK with COVID-19 were actually included in this study. So it's hugely representative. Nothing else I've read for COVID therapeutics even comes close to that. The primary outcome in this study was all-cause mortality at 28 days. And some of the secondary outcomes they looked at were progression of respiratory distress to requiring intubation and the proportion of people who were discharged alive at 28 days. The comparison in this study was patients were randomized, and it was a little over 2,000 patients who were randomized to the dexamethasone arm and a little over 4,300 patients who were randomized to receive usual care. There was not a placebo control in this study. Patients in the dexamethasone group got usual care plus 6 milligrams of dexamethasone a day, either oral or IV, for up to 10 days, or less if they were discharged or died, obviously. And the comparison group was just usual care alone, which they didn't really describe and probably varied somewhat at each of the study sites. So there were really not any inclusion or exclusion criteria for this study. This was pretty broadly representative of hospitalized patients. What was the primary finding of this study? Well, the authors reported a large absolute risk reduction in 28-day all-cause mortality associated with dexamethasone use. And further, we saw that patients who received dexamethasone who were intubated, who required mechanical ventilation, the sickest patients in this study actually had the biggest benefit. They had on the order of a 12% absolute reduction in 28-day all-cause mortality. And I think the relative reduction associated with that was on the order of a third. And patients who were on oxygen of any level also experienced a large and significant absolute risk reduction for 28-day all-cause mortality. Patients who were not requiring oxygen really did not see any mortality benefit from dexamethasone. In fact, there was a suggestion that those patients may have experienced harm from that, though that was not statistically significant.
Rahul, that was one of the two things that really struck me from this trial, that if you have a hospitalized patient that's admitted, they're not requiring oxygen, don't go messing around with steroids. And then the other question that I had asked you about in pre-recording was this. I just noticed that you would imagine the patients on mechanical ventilation were older and sicker, but it actually looks like they were quite a bit younger. And I just couldn't really figure out why that would be. And I didn't see in the paper where they speculated it. So do you have any thoughts about that?
Yeah, you're pointing out that the patients who required intubation in this study had a mean age of about 59, and the patients who didn't require any oxygen at all were 10 years older, so they were 69. And usually we think of intubation as a proxy for disease severity, thinking about the sickest patients are the ones who require intubation. So my hypothesis for why that group was so much younger, we know that early on in the pandemic, we were probably a little overzealous with intubating patients because we were afraid to use non-invasive ventilation and high-flow nasal cannula due to the risk of generating aerosols. And I think it was, I haven't been in this situation, but I think it would probably be easier to decide to intubate a sort of young, healthy person, without comorbidities. And you might sort of take pause, with the decision to intubate an older, sicker person who you're worried might not be able to come off the vent. That's my only sort of guess as to why the intubated patients might have been younger. I think it's probably not just a reflection of disease severity as we're used to seeing.
That's brilliant. Let me ask this. I remember when the press release came out, and of course, because Twitter is 90% of my world, there was a lot of skepticism. I think we being doctors as a group were just so punch drunk and felt so sort of beat up by equivocal studies or studies where the results were reversed, or what we thought we knew turned out to be wrong, i.e., say masks, so that when something came out that seemed this positive, it seemed too good to be true, and a lot of people were like, steroids, come on. So now that we have the actual study in front of us, can I be okay with this? Can I feel good about this study?
I think you should feel great about this study.
Thank you for that. Oh, God. I need this so bad.
This is going to end up being one of the most important pieces of literature from the past year, and definitely the most important treatment literature so far in the pandemic.
This is a positive trial, right, Rahul? So remembering what you've taught us about looking at these trials, if it's a positive trial, we need to look where were the sources of bias. Didn't see a lot in this trial. It was open label. Is that, other than that, is there anything else that you really found in it?
Absolutely. No, you're 100% right that with a positive study, we have to look for threats to the validity of that conclusion. So are there sources of chance or bias that could make a false positive study more likely? So, strict inclusion and exclusion criteria can sometimes introduce selection bias by creating a really highly selected study population. And, because this study was very broadly representative of the UK population of hospitalized patients, we are not worried about that. So, I'm not seeing a concern in terms of patient selection. Another source of chance, the patients in the dexamethasone group, just through kind of bad luck with randomization, ended up being about a year older on average than patients in the usual care group. And if anything, I would expect that to create a bias towards the null, because we know that older age is a risk factor for worse outcomes from COVID-19. So the fact that this study still demonstrated a reduction in all-cause mortality despite that imbalance in the unadjusted analysis, suggests to me that, their chance was not working in the direction of a bias towards a positive effect. And just that quick overview of major sources of chance and bias, this does not raise my alarm bells for, this being highly likely to be a false positive result.
So are we ready to talk about this as give it a Hotcakes rating, as our very first on the new scale? Is this a 5?
I'm ready to give this a 5 full stack Hotcake rating.
Wow. First rating of 5 Hotcakes. That feels meaningful to me. Any
special toppings? I know Sarah's a fan of the toppings.
How many David Burns would you put on top, Paul?
I can't. I'm ready to talk about statins whenever you guys are.
I do. Before we talk about statins and before we leave COVID directly, I want to give a shout out to the great Dr. Paul Sachs. And he's been writing, there's been 2 blog posts in the recent past that I've seen where he's talked about this home testing. And Rahul, I think you have some connection through your wife to this Michael Minna, who has been promoting this. And the idea with this home testing is that there's going to be these rapid, cheap home tests that are in development or available but not yet approved, where all you need is saliva, so it's not going to be painful, and it gives you a result in like 15 minutes or something ridiculous like that instead of 2 weeks. And even though the sensitivity is going to be low, Dr. Sachs is arguing that you would pick up people with the highest viral loads so they could feel safe going to work or going to school, whatever they need to do. Maybe going to the theater even, going to visit family. Rahul, what do you think about this sensitivity issue, false positives, false negatives? What are some of the pitfalls?
Yeah. I think that this is a really great idea, and it's kind of born out of the realization that our testing infrastructure for COVID-19 is unfortunately not where we need it to be at this point. Many parts of the country are still facing, long delays in turnaround time for result availability. And one consequence of that is that we are missing positive cases while people are still most infectious. So if we are able to switch to a system that's much more analogous to like a home pregnancy test, where, people can administer the test themselves, interpret the results themselves. And if we are able to mass produce this on a scale that people could, have a strip of paper that they lick every day, that could be really a game changer as far as identifying those people who are shedding virus in high amounts. And to me, the sacrifice in sensitivity is an acceptable trade-off here, because right now we are not identifying enough people who are infected, and switching to a lower sensitivity strategy that's much more accessible could be something that turns the tide in this pandemic.
Paul, did you have any thoughts on this?
No, nothing that would be as eloquent as was already said. Yeah, I think if it's a slightly not good test, used for more people seems good to me. So what Rahul said, except, less smart.
So I don't know. By the time this comes out, I doubt these tests will be available yet. But hopefully this will help get the word out about them, and people can, if you know people in high places, tell them you think this is a good idea. So with that, Paul, let's talk some statins, because there is more to medicine than COVID, which I'm being reminded now on a daily basis. Thankfully, we live in a state that's doing okay.
Yeah, sweet statins. I was so happy to talk. I'm so happy to talk about something kind of non-COVID related, though I'm sure there are plenty of sort of statins and COVID mortality studies out there that we can talk about some other time. But I wanted to talk about a paper that just came out. So this is the Association of Statin Use with All-Cause and Cardiovascular Mortality in U.S. Veterans 75 years or older in JAMA by Orkabi, Driver, Ho et al. And they looked at a question that I feel like comes up more than you might expect, where you have a patient over the age of 75 in clinical practice who probably should have been on a statin but was not. And I'm probably not even saying that right. That's not still the specific question that they asked. But someone who kind of comes to you de novo, perhaps, they're older, you think maybe they would qualify for a statin, but for whatever reason, they just aren't on one. And so the question they were asking is, in patients over the age of 75 who do not have known prior ASCVD, is adding a statin to their regimen associated with lower mortality? And so the primary outcome they looked at were all-cause and cardiovascular mortality, and the duration of follow-up was a mean of 6.8 years. So the population they looked at was from the Veterans Administration. So it was the Veterans Health Administration health system. And the users there, the mean age of this population group was 81 years of age. So not directly applicable to all of your patients. They were 91% white. They were 97.3% men. So again, not to jump ahead, but one of the, not criticisms or even really shortcomings, but one of the things you could say, this is maybe not necessarily broadly applicable, though they do make some arguments about that later in the paper. And they were identified by something called the VHA Corporate Data Warehouse, which is maybe the most dystopian phrase I've read in any study that I've ever looked at in my entire life. Just horrifying, but it seems like they're useful at least. So the patients they included in this study are patients without known ASCVD and patients without known statin use at the time of inclusion. What they did is they actually sort of followed these patients along. It's a retrospective cohort study, so they didn't actually follow them along, but they sort of looked at their care retrospectively and then looked at patients who were then started on a statin during the follow-up time period, and then compared those who were started on statins versus those who were not in terms of the primary outcome and then also the secondary outcome, which was ASCVD events. And so what they found is, I think we could characterize this as a positive trial, and that new statin use was significantly associated with lower all-cause mortality and also the cardiovascular mortality. And then even the secondary outcome showed lower significant ASCVD events, which are categorized as things like MI, TIA, stroke, revascularization.
Paul, to quantify this, and maybe
this is
maybe, and if you can't answer this, I'm sure Rahul can.
Yeah, sure.
This idea of person years, because one of the ways they reported this data is that there was the people that were on statins had a lower risk of death, like all-cause mortality. It was 78.7 per 1,000 person years versus 98.2 per 1,000 person years. So that's a difference of like 19.5 years between the statin group and the non-statin group. And for me, when I look at person years, I'm like, sure, what's 5, 10? That sounds good.
Yeah, sure. No, less death seems good, but why don't we defer to the person who actually knows what these numbers mean?
Oh man, I feel like this is a trap. So
yeah, because Rahul, it seems like it's a little bit of a subjective thing whether or not this is meaningful to you,
right.
Or if you're like a population health person looking at this, like whether or not it's meaningful to you.
Yeah, I mean, and I think it is useful to think of these data from the perspective of the health of the population, and when you're thinking about person years, I mean, it's kind of a flexible thing. You could think about, if you have 1,000 people over 1 year, these results indicate that we can expect starting a statin after age 75 to be associated with about 20 fewer deaths as compared with patients over 75 who never started a statin. And there are some limitations to that we'll talk more about. But from the perspective of person years, I mean, this kind of allows comparison to other interventions. So it's kind of a nice thing. And it also allows extrapolation to the population as a whole. As we're sitting talking about this, I'm looking up the number of people in the United States who are over age 75. So the the potential target population of these data. And the Census Bureau is indicating that that's about 18 million people as of at least 10 years ago. So if we extrapolate these results to the entire U.S. population, we get, I'm just doing the calculation right now. That translates to about 360,000 fewer deaths for that entire population in 1 year. So has a potentially large impact at the population level when you look at it that way.
That's a lot of grandmas and grandpas still living.
Absolutely.
Or just weird old. We'll cut that out.
People. Why don't we just do people? Yeah.
So
that's. We had to make it sad.
I had to make it sad.
Fine. I'll start a statin with everybody. It's fine. So, Paul, by not prescribing statin,
all right,
you killed 300,000 grandmas. So,
Claire,
now leave all this in, Claire. Do not cut this out. This is all gold.
This is coming from me, who loves older adults and geriatric medicine. So, this is great news, Rahul, that we can have such great impact. Okay, thank you for doing that back of the envelope calculation. Paul, what else do you want to talk about with the statistics about this study?
Yeah, so one of the things that they mentioned, that there's a lot. Obviously, I'm so happy, as we mentioned every time that I've been involved in a Hotcakes show, where typically I would say, and then statistics happened, and then move quickly to conclusions, to have someone who can explain exactly what they did. But one of the techniques that they mentioned was using this propensity score overlap weighting, and then they also sort of followed hazard ratios every 2 years. It was just some interesting stuff that, to me, I didn't quite fully understand sort of what they were doing or to how that was beneficial. So I wonder if you could just sort of, in broad strokes, talk us through the statistical analysis they did to actually come up with these data.
I'd love to. And I'll just say that on balance, in this study, these authors really did a lot of the sort of best practice things that are available to try to account for the fact that this is not a randomized trial. This is observational data that we're using to try to tease apart what the impact of this one specific exposure is on the outcome of interest. So, I mean, overall, I think the authors did a great job of using the tools available to try to do this. But with propensity matching in particular, I think it's always useful to remind ourselves that, like, what is the problem that propensity matching or propensity score weighting is trying to fix? And it's trying to fix the fact that this is not a randomized controlled trial. So the allocation of the exposure or the treatment, in this case statins, was not random. It was dependent on all of these measured and maybe even some unmeasured covariates that were different between the two groups. So if you just look at what happened to these patients in terms of outcomes, you need some way of accounting for the fact that they have different likelihoods of getting the treatment, simply because some of them did and some of them didn't. So what the authors did in this paper is they used a method that is quite sophisticated, in my view, to try to do that. And all people need to know about this, in my mind, is that they basically calculated a probability for each patient to get the treatment, either statin or not get a statin, based on the measured covariates. So this doesn't include unmeasured things, okay? This doesn't include things we don't know about. And then they used the likelihood of whether somebody was in the other group to come up with a strategy to match these people. And the benefit of this is that this really is robust to extreme likelihoods. This is very reflective of people kind of in the middle probability range. And this also produces really precise estimates of the treatment effect. So we should expect to see narrow confidence intervals, small p-values, very precise estimates of the truth.
I'm excited to hear you say that, because actually one of the things that I noticed, and I was very proud of myself for noticing, that the confidence intervals were in fact extraordinarily tight whenever they were talking about the specific hazard ratio. So it seems like that it did the job that it was supposed to do.
Yes.
Paul, something else that I wanted to bring up about this, which surprised me, the bigger delta between the groups was for all-cause mortality, not for cardiovascular related death. So, Paul, does this suggest a pleiotropic effect of statins and that we should be putting them in the water?
I had like a 3 or 4 month run where I wasn't doing Hotcakes, and I thought I was fired from them, and I felt pretty okay about that. And I'm starting to remember why I hate them so much. Yeah, so I guess, thank you, Matt, for that transition point. So from a bottom line standpoint, what do I take away from this? We were talking before recording. This is a good study. I'd want it to be flawed. I would like to find huge problems with it, because I thought that we were past this point where just starting statin therapy would be enough to sort of magically reduce your risk for ASCVD events or mortality. I thought we had fairly firmly established that was LDL cholesterol lowering. I thought we established pretty strongly that, there's no point in locking the barn door after the horse has been stolen. And now we're sort of back to this. After a mere 2 years of starting statins in the patients, they actually had lower events. And so I don't want to think about pleiotropic effects. I don't want to talk about plaque stabilization. I don't want to hear about any of it. But also it seems to be that just starting statins seems to actually have mortality benefits beyond. I just don't want to think about it, Matt.
Did you want to assign a number of hotcakes to this, Paul? This sounds like this is towards the upper end of the scale.
Don't give him an option, Matt. You just have to ask what the rating is.
Yeah, no, thank you for moving us through this. I want to mention a couple of other things real quick, if you don't mind.
Sure.
Is that just that I noticed that simvastatin was the statin du jour of the time of the study, which is sort of interesting and kind of different from our current practice pattern. So worth noting, I don't think it actually really negatively impacts the quality of the data at all, but I think it's just sort of worth saying out loud at least. And I felt like I had one other genius point, but I think you distracted me with the hotcakes, which have just been lurking behind me this entire time. So if I were with our new system that is validated and scientific, I have to give this 4 hotcakes. And even though I hate giving any amount of hotcakes, I think that it answers an important question. It will probably actually change my practice. I will probably be more inclined to provide statin therapy in older patients if I think that their life expectancy actually warrants it. But I think it's actually an important study that is practice changing.
That's where I wanted to go with this, Paul. The authors had some really nice factoids in there, one of which was that if someone reaches age 80, life tables predict that person may have another 8 to 9 years of life left. And statins, it seems like the time to benefit is something like 2 to 5 years. So if you have what you think is a reasonably healthy 80-year-old, they might live another 8 to 9 years, and statin can have benefit within 2 to 5 years. And then another fact that is kind of along this hand-wavy pleiotropic thing, Paul, is that it seems like statins have a 2-year legacy effect when patients stop them.
Sure. Yeah.
And maybe that's why there isn't. We've talked about a trial way back. Stopping statins within the last year of life probably doesn't matter because you can still expect that there's some sort of legacy effect for a little while, maybe up to 2 years.
I think the thing that I found most interesting is if you stand in a darkened bathroom and say atorvastatin into the mirror 3 times, the statin fairy comes along and just stabilizes all your plaques. So it's I don't think I considered that in my consideration of prescribing as well. So
I thought you were going to say make a Candyman reference, Paul, but okay. So let's go on to the last trial. Thank you, Paul, for assigning a hotcakes rating. The final trial is one that I'm going to be presenting. It was the TICO randomized trial by Kim et al. It was in JAMA in July 2020. And this was looking at ticagrelor monotherapy versus dual antiplatelet therapy after an acute coronary syndrome. And the reason I wanted to do this is because I've been really interested. I guess it's probably the past 2 years, Paul, we've been seeing these articles of shortened dual antiplatelet therapy after PCI or after acute coronary syndrome. And this trial was specifically looking at acute coronary syndrome and specifically ticagrelor. And I don't really use that. Paul, do you see a lot of ticagrelor? And Rahul, same question to you.
No, not at Cashlack Northeast. That is not our anti-platelet regimen of choice there.
Only occasionally. I'm still seeing mostly clopidogrel.
And then the other one, so ticagrelor and prasugrel are what are referred to in the literature as these high potency P2Y12 inhibitors, which I didn't really make that differentiation. I was just like, oh yeah, they're all like, there's clopidogrel and then there's these other ones, but apparently these other ones are thought to be better, but they have a higher bleeding risk. So something that I just wanted to point out, since as general internists we may not be as familiar with the side effects, is that ticagrelor has a warning that in patients at risk of symptomatic bradycardia, including the types like 2nd and 3rd degree heart block, it should give you pause and you may avoid that medication, which I had no idea about that side effect. In this trial, which was done in South Korea with over 3,000 patients, so the question from this trial was, is monotherapy with ticagrelor safer than dual antiplatelet therapy after drug-eluting stent placement for acute coronary syndrome? And basically what they're asking, was there less bleeding, but was there no increase in adverse cardiac events? the comparison here, so everybody got 3 months of dual antiplatelet therapy, and then at 3 months, patients either were randomized to receive ticagrelor or to remain on dual antiplatelet therapy for the rest of that 12-month period. And then they were tracking bleeding and major adverse cardiac events, which always include cardiac death, MI, revascularization, or stroke. And the results were that they really didn't see an increase in major adverse cardiac events in the monotherapy versus the dual antiplatelet therapy, but they did see less bleeding. So this was a positive trial, but there were some limitations. Rahul, they talked a lot about the power calculation in this. They were expecting something like 18% of patients, the rate of the primary outcome, which was either bleeding or a major adverse cardiac event. They were expecting a rate of like 18%, and it ended up being a rate of around 6% in the dual antiplatelet group. So how might that have affected this outcome here and their power calculations?
Yeah. I mean, first, I'll just say that this choice of net adverse clinical outcome is a little unusual because we're used to seeing, major adverse cardiac events, things that all have to do with kind of, not enough platelet inhibition. And then we're used to seeing, as a secondary outcome or maybe a separate primary outcome in another study, bleeding events, which is, probably related to too much platelet inhibition. So the primary outcome in this study was a composite of kind of, both ends of the seesaw there. And so that's really patient-centered because patients, care if anything bad is going to happen to them. Doesn't matter if it's a ACS or bleeding. There's obviously subtleties to that, but I think that's kind of one of the unique things about this trial was the choice of an outcome that included kind of both ends of the spectrum of platelet inhibition. Sequela of having too much or too little. So the power calculation that you ask about, I mean, usually power is only informative when you're talking about appraising a negative study, because if you have a positive study, then you have a confidence interval that, doesn't cross unity. And so you can, make a judgment about do the ends of the confidence interval make sense to me? Is this too wide or is this appropriately narrow? So this study, the primary outcome, this was a positive study. Patients who were on ticagrelor monotherapy had less composite badness happen to them. Okay, so that's good. But because they had fewer cardiac events in this study than what they were expecting, you have to wonder if you generalize these results to the real world where, people, probably have a higher risk because trial participants tend to be healthier. You have to wonder, is this negative finding for cardiac events a true negative, or is it just that there is a difference but we didn't have enough people to find it? So that's what I think they mean by their caution that the study could have been underpowered. The fact that there was a positive finding for the subgroup of, or the subset of the outcome of bleeding events, I sort of trust that because with fewer events, if you still see a difference in, a component of the outcome, that's unlikely to be a false positive from a power standpoint. So, but the false negative is what you have to worry about. So with generalizing this, you have to think, the bleeding part is going to be probably an accurate reflection of reality. But, whether or not patients on ticagrelor monotherapy are going to be more vulnerable to major adverse cardiac events, that's the part of the question that in my mind is not quite answered firmly by this study.
Yeah. To make sure I'm understanding correctly, the bleeding thing was handicapped here because there weren't as many events as we would have expected. And I think the authors even said they did exclude some patients who were at higher risk of bleeding, but they still found a benefit of decreased bleeding. So that's pretty robust. We can say that's probably real. But the fact that there weren't a lot of cardiac events, we don't know for sure if the monotherapy would hold up. If we had enough patients and enough events, we might have seen a difference between dual antiplatelet and monotherapy. We don't know if it would have been good or bad, better or worse.
That's right. I mean, there, to try to answer that, you can look at these results in the context of other literature, and talking with content experts would be a really useful question to ask somebody. There was a randomized trial a few years ago called the Twilight study where they, asked basically the same question, but their primary outcome was split between ACS and bleeding. And that study did also show a lower incidence of bleeding with monotherapy, and pretty convincingly no increased signal for major adverse cardiac events. So that's another tool we have in terms of trying to interpret the outcomes of this study.
Yeah, and I should mention there's also just from June there was a meta-analysis, a systematic review and meta-analysis in Circulation that included this study, and it was looking at this question of early discontinuation of aspirin and after either PCI or ACS, and they again found it seems like it does reduce bleeding risk without really having an increased risk of cardiac events. So this study, I'm not going to give it. I'd say this is probably a 2 or a 3 on the rating scale, especially because the patients in this study, they were Korean patients. They had this really fancy, ultra thin sirolimus drug-eluting stent. They were getting this fancy medication, Ticagrelor, which not all of our patients get, and whatever else we just talked about with the power calculation. So I think this is a 2 or a 3. I do think that the evidence is accumulating, and I think probably in practice, probably next time guidelines are updated, we'll see a shorter duration of dual antiplatelet therapy when people, and probably people will be on monotherapy with one of these more potent inhibitors, but we'll have to learn about how to use them as general internists because both prasugrel and ticagrelor have some warnings associated with them. With prasugrel, it's mainly bleeding in people who are older or underweight or have had a previous stroke, which seems like a lot of my patients.
Right. Yeah. Yeah, you would think that'd be a large subset.
Yeah.
That's nothing to sneeze at.
So any other business, or is this a wrap? Are we ready to go to the outro?
I mean, we're fully committed to the Hotcakes scoring system. Do we feel good about it?
Yeah, I feel really good. Rahul, I think you've made a wonderful contribution to evidence-based medicine moving forward, and I wouldn't be surprised if some journals pick this up.
I mourn the loss of our hilarious takes about things on hotcakes and silver dollar hotcakes and chocolate chips. It's just, I don't know how our listeners will do without that level of humor that they've come to accept. So
I welcome the.
I think they still become spooky. Yeah. They still become spooky cakes in October.
I think we're invalidating the system. I don't like that at all. I worry about the integrity of our rating system if we do that.
All right, let's do it. Outro. Paul, do you want to do the honors?
Sure. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Yeesh. I need to take a moment.
She's the best at that.
The Curbsiders. What's that?
I said she's the best at that.
I mean, again, I feel like it depends on sort of what your rating system is. But get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecurbsiders@gmail.com. A special thanks to our producer for this episode, Sarah Phoebe Roberts, and to our social media team, Beth Garbs Garbatelli on Twitter, Maddie Mad Dog Morgan on Instagram, and Chris the Chew Man Chew on Facebook. Until next time, I've been Dr. Rahul Ganatra.
And I've been Dr. Matthew Frank Watto.
And this has been Sarah Phoebe Roberts. Thank you to Stuart for composing our theme music and to Claire Morgan of Naughterly for editing our audio. Thank you and good night.
Yeah, I'm still Paul Williams, by the way, if anyone cares. Throw that in there at the end.
Oh.
Just go ahead and edit me right out of the script there, Sarah. That's cool.
Oh, hi, Paul. And thanks to our partner, VCU Health Continuing Education, who's helping us offer free CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information.